Ryan Stanton here with ASEP Frontline, joined by a guest that we had a couple of years ago. Return again, live recordings from here at Emerald Coast Conference in Destin, Florida, with Dr. Randy Sorge. And a couple of topics here, talking about burns and as well as team dynamics. And I want to talk about team dynamics because it's a topic that we don't consider a ton. But as emergency medicine, we know that it takes a team, probably more than almost anywhere else in the hospital or in the healthcare setting, is the team necessary, the dynamics and the working together of the physicians as well as the nursing and tech and whatever support staff and everybody else that's involved across the board to make emergency medicine happen and make it efficient and a supportive environment. So he's got a talk here, actually ducked in for some of it as it has happened in the past tense here at the conference, and wanted to pull him aside and grab some of the nuggets from that to pass on to you. And those that can't make it to this conference here in Destin, you should try it next year though, because it's one of my favorites that I go to every single year. I think it's 15 years in a row now. So Dr. Sorge, kind of give us a little bit of background and tell us a little bit about yourself.
Hey Ryan, thank you so much for having me today. I really appreciate it. I am originally from Connecticut. I currently work at LSU in New Orleans. I'm a New Orleans transplant. I did my training at Mount Sinai in New York, and I'm an APD for LSU. I also help run the clerkship, and I'm really interested in the leadership aspect part of emergency medicine. That was one of the main things that got me into emergency medicine to begin with, is just how to orchestrate and run a diverse team of different types of clinical providers. And I got interested in communication, team dynamics, conflict resolution, and all those types of topics just because I ran into so many hurdles in the clinical environment myself, trying to get things done. And I was like, there's got to be a better way, So I picked apart some literature, a lot of stuff in my presentation comes out of Harvard Business Review. Some comes out of, different types of HR literature. And I was like, how can we translate this to the clinical environment? How can I apply it to our practice to make my day-to-day better?
So let's talk about that definition of the team and the dynamics within emergency medicine. Kind of give us that breakdown and then why that's going to be so important for us in the EM setting.
Yeah, team dynamics is just like what it sounds like. It's just about how people interact, how they communicate, how they get along, And as we all know, that can either be good, bad, or anything in between. But I think that our role as, ER physicians, we just have a lot of power to influence that dynamic and to make it better. I always see myself as, the WD-40 that's just trying to grease the rusty wheels in the machine, right? Between us, the nurses, the consultants, patients and their families, et cetera. And so I think that that's kind of like the essence of what it is for team dynamics.
And actually, it's one of the things you mentioned. Not only, we have that opportunity for good and bad potentially, that we can actually, as physicians, we have that potential to push it in both directions.
Oh, definitely.
Of being able to make and build that team atmosphere, that interdisciplinary team atmosphere, or potentially be just the opposite of that WD-40 reference and actually cause more rust on those cogs and make it more difficult. So let's talk about that ED team and how are we unique with that team approach and impacting the front end of the hospital and acute care process.
So there are obviously very different types of teams, okay? And what we do in the clinical environment is so different than what they do like in the business world, right? So our clinical team in the ER is what's known as an interdisciplinary action team, which is like a bunch of fancy words. But what it means is we're composed of highly specialized members that basically have to cooperate and get along and perform important tasks in a ever-changing situation, right? It's very dynamic in the ER to basically deliver good patient care. And then, of course, we have the added bonus of trying to simultaneously train and develop more novice members of our team, as if it wasn't difficult enough.
And then not to mention the fact that, expectation of near perfection in terms of the clinical care we provide, but also expectations on the interactions with the staff as well as with our patients and their families. Dealing with them, the patient satisfaction, which I know makes us all kind of cringe a little bit, with seeming to be more and more moving towards that satisfaction industry, when most of us want to make sure that the primary focus from a physician standpoint is going to be that being able to that relationship with our patients and their families in order to get the information, make efficient diagnoses, and the safest interventions and treatments that we can. So one of the big things as the physician in the group is we're obviously seen often and should be as a leadership position within the emergency department. And I think one of the biggest things for emergency medicine moving forward is being that leadership positions within the hospitals. But just within the emergency department right now, seeing as a leadership position, how as a physician do we manifest qualities of good leadership, and what makes up and the aspects of a good leader?
Yeah, that's a great question. I mean, so I think that the major factors that come to mind when we're talking about what makes a good leader in the emergency department is three things. We got to be functional, we have to be dynamic, and we have to be able to either share or delegate roles. So when I mean that we're functional, I mean that, we got to get work done, right? Tasks must be completed. Patients need to be disposed. Patients need to be treated. At the end of the day, that's the bottom line. But to be a good leader, we have to, in order to obtain that kind of functionality, we have to kind of provide some overall structure for the team and some sort of direction. We always have to monitor tasks, make sure that we're following up, that things are getting done, coach members of our team up, and we have to, in addition, be clinically competent ourselves, because a lot of times we're going to be, even in a training environment, we're going to be expected to perform our own hands-on tasks. When it comes to dynamics, that's something we are very familiar with. The emergency department is constantly changing, and so, but our teams are changing as well, right? Every shift, you're working with a different group of nurses, a different group of residents, a different group of consultants, and so that keeps you on your toes, but the experience level of the people that we work with is often different. So I work at an academic institution. It's totally different if I'm working with a fourth year ready to graduate, right, in like a few weeks versus, an intern that's coming in a few months. And so that's one part of the dynamic situation. The other part is the extrinsic things, that are pushed upon the team. Do we have 50 deep in the waiting room today, 20 deep in the waiting room? What's the acuity of patients that we're seeing, and what kind of resources do we have available? Over COVID, obviously, we had very sparse clinical resources, which made us getting our job done a lot more difficult. So that's function, that's dynamics, and the last thing is sharing and delegating. Again, I work in a training environment, so when it comes to being a good leader, I often have to adopt the pilot co-pilot model, and I know you're a pilot yourself, and so you know how important that is. But that's how you are basically learning to take over steering the ship, so to speak. And even if you don't work in an environment like I do in an academic setting, I can think of like when you're doing a major trauma resuscitation and it's me and the trauma attending simultaneously co-managing the resuscitation to deliver care. That's very different than just having one cook in the kitchen. So I think that those three characteristics are unique to what we do in the emergency department and help us function as better leaders.
But to be a good leader, we need a good team.
Without
we have
a
to
doubt.
build a good team.
Yep.
And so that kind of rolls into that larger component, as the physicians working with nurse leadership and being a leadership position within the emergency department, the key is building that team. And whether in your case in an academic setting, my case more of a, not rural setting, but more of a community-based setting, but also a lot of different settings across the country, that team dynamic is going to be key. And the dynamics are a little bit different between whatever setting you are, especially with academics with that larger accoutrement of residents and students and all levels that kind of break down through there. But the team dynamic is still going to be an important role throughout, no matter where you are. So what are the characteristics that we need to look at to establish a strong team for every shift, or as many shifts as possible when we go into the emergency department?
Yeah, so a lot of these terms I'm about to use, they sound like little buzzwords or vocabulary words, but I'll tell you what they mean. So characteristics of a good team is you have to have good alignment. And what I mean is your goals have to be aligned. Everybody's got to be on the same page. That's all that means, right? And so each member of the team needs to understand the directions and the goals. When there's ambiguity about what my job is, what my responsibilities are as a member of the team, it's really hard for me to accomplish those tasks, right? I'm not going to be a functional member of the team if I don't really know how I fit into the bigger picture. So that's what I'm talking about when it comes to alignment. The other one is transparency. And transparency is just, any kind of team, doesn't matter if it's a group project in high school, it doesn't matter, if it's a sports team, whatever, there are always going to be issues. It's inevitable, right? And so when issues come up, you have to have a culture of transparency, okay? So addressing issues head on with openness, honesty, and respect are super important. Notice how I didn't say judgment, because that's like a big one that I've hit up before in our environment that tends not to work well. But when it comes to transparency, if people think that there's something to hide, then they kind of become suspicious, untrusting, and that's just a surefire way to really have the team dynamics suffer. And the last thing is accountability. Again, the group project mentality. We've all been on group projects before in high school and college. Lack of accountability drags down teams. When there's that one member that's not pulling their weight, that's not meeting their deadlines, that's not accomplishing their tasks in a way that helps move the team forward, it doesn't work. So ensuring that each team member is aware of their responsibilities and really emphasizing the importance of following through is critical to having a solid team.
And one of the keys here, and I mean, obviously all three of these are going to be huge. And I think we make the assumption as physicians on the alignment that we're all in it for the patients and their families, for the best outcomes. But you have to look at it, especially now with some of the directions of medicine, whether it's systems, the corporate aspect of medicine, or even as far down as the individual goals of what they're trying to accomplish, each person in the department. That it seems like the alignment's obvious, but it's very important to drive home that we are there on the same page for the patients and their families and their outcomes, because there's so many different things, like especially right now with trying to make sure we click metrics, we check off metrics that we did such and such in this amount of time. That's not necessarily a patient-oriented outcome, and that's a challenge when we get our eye off the prize of a patient, a value-added patient-oriented outcome. We can check all kinds of boxes, but is it really in the benefit of the patient? Transparency, that is a huge one. Those open lines of communication, which in the history of medicine have been very challenging, especially with the punitive nature of medicine, especially when you're dealing with physicians. Sometimes that punitive nature of being open with the physicians, and it's very important, especially in the emergency medicine environment, that people can feel open and free to communicate, especially concerns that may be there. I mean, your nurses and your techs and everybody else should be very comfortable being able to come up to you and bring up a concern, something they're observing, because I've, just thinking back to this last week, a couple times that the nurses have saved my hide. Just observing something during the course that just didn't make sense with the way the patient was acting or something that was going on. Say, hey, doc, you mind coming back and rechecking and looking at this and and reassessing? Yes, absolutely. I think that's going to be really important. And of course, the accountability aspect of things. And there's going to have to be things or conditions out there that are going to help us build these dynamics. Because they seem obvious here, but we're not always seeing those in our settings. There's so many different hands in the pot in terms of pulling people different directions. What are some of the things that we're going to implement, that we can implement, that are going to help to build these good team dynamics?
So I think, we're talking about basically what conditions are going to help make a good team, right? And so there's some similarities between the qualities and the conditions, but I'll say that one of the conditions is having a compelling direction, right? Mm-hmm. Having a goal that is shared, a shared goal, is going to help address that alignment issue that we talked about. So I think that when it comes to goals, a team can't be inspired if they don't know really what they're working towards, right? So you got to set a goal. It's got to be specific, okay? And it has to be modestly challenging. If it's too challenging and it's impossible, like, hey, we're going to clear the waiting room, even though, there's 5 hours left in the shift and there's 50 patients in there, like, people are going to be like, yeah, we're never going to clear the waiting room. That's not going to happen. So it has to be an attainable goal. But if it's too modest, then it's not going to be motivating. Similarly, when it comes to having a good goal, specific, challenging, and there has to be some sort of incentive. Now, in our environment, again, I work in academics, there's no RVUs or anything, so there's no financial incentive, but there are other incentives to doing good work. And I think that would have to do with, like an extrinsic incentive would be something like recognition, like, hey, you did a really good job on shift today, I saw that you were hustling, I really appreciate that, we couldn't have done it without you. That's an extrinsic incentive, right? Being recognized. Another thing would just be, deriving some sort of intrinsic incentive, meaning that, I feel satisfaction and a sense of meaning because I know I did a good job today. And so I think those two things would be the things that we rely on in the clinical environment to incentivize people to meet their goals. Another thing I think about is, having a diverse team. Now, we're lucky in the ER because our teams are always diverse, right? You think about like superhero teams, like everybody have a different superpower at, in the Justice League, right? You can't have 3 people with super strength. It does not work that way, right? Now, in the clinical environment, we're already set up because, my skill set as an MD is different than the mid-level provider, is different than the RN, is different than the respiratory therapist, is different than, my consultant, the cardiologist, whoever. And so we're already set up for success by having a diverse team. Again, it's just about getting that team to work together and to unify them and have them see themselves as one. The other thing I think about is just support. And I mean both physical support and emotional support. When I'm talking about physical support, I mean you got to give people the tools that they need to actually do their jobs. I can't tell you how many times over COVID, there's not enough PPE, there's not enough, 18 gauge needles to draw up medications or, to perform procedures. None of us can function as a good team and accomplish our goal of delivering patient care without the actual supplies. And then the other support, the emotional support, is just about being like, we got each other's back. We're in this together, I'm gonna be there for you, you're gonna be there for me. And I think that you can't have a well-functioning team without all of those elements.
Well, then we've got those that are supportive. Let's talk about some of the torpedoes that are out there. So what are some of the things that are going to erode the team dynamics?
Oh, yeah.
The things that we may not even think about that may just start to poison the drinking water.
Again, these are going to sound obvious and a little simple. They are, but this is just the nature of communication, okay? So language matters. It matters a lot. And so using language that shirks responsibility, casts blame, or creates divide is going to destroy the team. Now, we are all susceptible to this, especially when it's been night 5 of 5, you're hungry, you're tired, you didn't sleep well, then it's easy to be like, hey, that's not my job, or use terminology like us versus them, and that's very common, especially when it comes to difficult consultants, But the truth is the consultants are a member of our team. I got a patient with an appy, I can't take care of that patient any other way than to have the surgeon be a member of my team. Got a patient with a STEMI, I need the cardiologist. And so I think that trying to model good language, okay, and also politely, kind of correcting bad language in a way, or having people rephrase it in a way where it's not so divisive can be helpful. Because using language like that, it breaks people apart. The other thing I think about is any interaction that's not face-to-face is a threat to good team dynamics, okay? Especially phone calls, definitely emails, and if y'all use Epic, the little secure chat function, oof, is it easy to get snippy in there, okay? So nursing communication orders, like I said, please get another set of vital signs, exclamation point, people hate that, all right? So when possible, and I understand that in our busy environment, it's not always possible, but whenever possible, do it face-to-face. I think that people are more respectful. They understand each other more. There's a lot of, most communication is nonverbal. And so you lose all those nonverbal cues over the phone, and it is easy to get persnickety over the phone, things like this. Now, of course, consultants are coming from home. There's nothing we can do about that. I'm not going to knock on their bedroom door to wake them up. So when I can't do face-to-face interactions, my backup is just watch my tone. Most conflicts have to do with not what is said, but how it's said. And, again, I've made this mistake a million times. I'm sure I still will, but I try to be mindful, especially when it's hour 11 of 12 on my shift and I got to call somebody, is watch my tone, how I talk to somebody, because that's most of the communication. And that's a lot of times where conflict starts to erupt, basically. And then I'll just say the last thing is when you either form or vocalize opinions with incomplete information, it's going to be a way to destroy teams. And what I'm talking about there is the rumor mill, right? So as soon as you start formulating an opinion and telling everybody like, oh, you wouldn't believe what happened today on shift, blah, 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 this person, blah, blah. I mean, that's just going to get everybody's feathers ruffled, start up the rumor mill at full speed, and it's going to lead to a bad team environment. And so trying to put the kibosh on that, I always tell my team, like, you got to keep the drama knob turned way down low, like while I'm here, all right? Because that's how we're going to accomplish our tasks better. And so those are the conditions that I think are most threatening to teams. Being careful with your language, doing as many, any kind of non-face-to-face interaction is going to threaten a team, and then the rumor mill.
And number one, I think, one of the big things for your number 2 point there in terms of communication, face-to-face communication or whatnot, especially, you learn this in residency, is once you have relationships with the people that you're talking to, it becomes much easier.
Oh, yeah.
And that's even more so in a community setting. And it seems like it takes, a couple of years, and then there's a good transition about the 5-year mark, and then 10-year mark after that, it's just like a bunch of old friends talking. And that makes a huge difference. And we actually talk about this in my group. We've been very fortunate in the group that I'm with. It's a single hospital group, and we've only had a couple of people leave in the 30, 35 years that we've been working in this hospital. Most people retire out from age rather than any other loss, and you can tell the difference in the interactions. I'm kind of in the middle right now. I've been there 8 years. Is those that have been there that 15, 20, 25, 30 years versus those that are brand new and the way the consultants interact with them. And a lot of that has to do with that building relationships. Do you know them? Mm-hmm. Do you know them outside of the ER setting? Are we always calling them with work to do versus we know about their families, we know about their interactions, we've been to events with them, building that, those friendships and relationships make a huge difference. And I strongly encourage everybody, to do that as you work into your jobs and into your settings, is getting to know the people that you're going to be talking with and working with, because that makes a huge difference. And even as simple as in our settings in the hospital, which is challenging with the turnover rate of nurses and techs and other support staff, is getting to know them and who they are and some of the things that are important. Just as simple as asking them about family and friends and things that are going on and being supportive. That can go a long way in terms of building that team dynamics. But what are some of those other tips? Everybody's got the information now. You kind of run through some of the do's and don'ts and the characteristics and reasons for the team aspect of things. What are some of the tips that you can help folks transition now from listening to this podcast to their work environment that are going to help foster the team-based culture?
Yeah, absolutely. So, we talked about some terminology, some vocabulary, which is a little philosophical, but the real meat of the talk is, what do I actually do on my next shift to improve team dynamics, right? People want practical tips on how do I actually accomplish these things. And so, I'll just give a little disclaimer that everybody's clinical environment's a little bit different. I don't work in your clinical environment, so my advice, you got to adapt it to whatever the culture is at your program. But I'll talk about a few things that I think work for me and are general enough that probably can be applied with some modifications. So one thing that I do is I always do a team huddle in the beginning of the shift when I come on, and you got to keep it brief. It's the ER, so no more than 3 minutes, and I get everybody involved. So me, the residents, the nurses, the EKG techs, environmental services, whoever's working together with me in that department that day, let's get together for a 3-minute team huddle, okay? We go around, we do introductions. I introduce myself, and I expect everybody else to introduce themselves by their first name, their role, the area that they're working in, and what shift they're on that day. So, I'd be like, hey, my name's Randy. I'm the ED attending for the day. I'm going to be working in pod 2. I got all 14 beds here. And, I'm here until 3 p.m. today. If y'all have any problems, let me know. And then it goes to the next person. I'll say that towards the end of the team huddle, after everybody's gone around and done some introductions, then I'll, take up the mic, so to speak, and just go over what I think are the most important priorities and expectations for the shift. So my expectations is that, we find sick patients, identify and treat them. If you have a patient that you're worried about, come to me, come to one of the senior residents, let me know early. Another one of my expectations are, if y'all are hitting a barrier somewhere along the way, let me know early on. There's a backup NCT. Pharmacy hasn't verified the medication. There's a behavioral issue popping off in the back of the ER. Let me know so that we can address that early on. Those are my expectations, that the staff come to me with any problems so we can kind of smooth it out and keep the shift nice and smooth. And then at the end, before we break up, I'll just say, very explicitly that, we succeed as a team, we fail as a team. Like, our goal is to take care of patients today. Everybody here is important. I expect that everybody's going to be, treat each other with respect. And, our success is directly linked to how well we work together. Break. And so that's how I do it. I do a team huddle, 3 minutes in the beginning of my shift, and that's kind of my little mental checklist. I got a whole bunch of other tips and tricks, so feel free to interrupt me. But the other thing I like to do is try to manage up my team members as much as possible. And what I mean by that is, I go into a room, EMS drops off a patient, they're brand new, we're hooking them up to the monitor, it's me and the nurse, and I'll be like, introduce myself to the patient, I'll be like, hey, I'm your doctor, and Crystal's your nurse today. She's one of our very best in the ER today. You're gonna be taken care of. You'll be in great hands. If you have any issues, she's at one of the mobile computers outside your room, and I'm just not too far away, all right? So don't be afraid to ask if you need something. We also have little whiteboards in the rooms. I usually write up, the names of, who the doctor and who the nurse is for that patient for the day. But I think the key of talking up the nurse in front of the patient is it makes them feel good, And when they feel good, they tend to be a better version of themselves. Now, is every provider I work with in the ER, the best nurse I've ever worked with? No, but a lot of them are. But I'll say that if I want them to be their best selves that day, it only helps to talk them up, And, I do it for my residents, my nurses. When I'm coming off shift and handing over care, I'll be like, hey, it was such a pleasure taking care of you today. I know you're still waiting on that CAT scan. I'm actually coming off shift, but Dr. Stanton's coming on. He is one of our very best in the emergency department. I checked out to him. He knows what you're waiting on. He's here for you if you need anything. He's one of our best doctors we got, so you're in great hands. It makes the patient feel good. It makes you feel good. I think it tends to set you up for more success on shift. I'll always do routine check-ins with the nurses, how's everything going with the patient, et cetera. What I've learned the hard way is if I say kind of some vague questions like, oh, how's everything with the patient in room 5? They'll be like, oh yeah, that's fine. So a vague question gets a vague answer. And then by the time I'm over to room 8, checking in with that nurse, they're like, oh yeah, I forgot to tell you, they actually need their pain medicine redosed, and the x-ray, the order was put in wrong. It's supposed to be the right lower extremity, but it's actually left lower extremity. I'm like, oh, okay, fine. So what I've learned to do is ask a lot more specific questions when I do my check-in. So if I'm in room 5, I'll be like, oh, hey, is there pain control? Do they need any additional medication for nausea? Okay, let me know if there's any problems with the, throughout the shift, I'm gonna go move on, whatever. But if I ask more specific questions during my check-ins, I'll get more information, And so I'll always check in. That kind of helps me stay on top of stuff and, helps the team function a little bit better. Again, identify barriers earlier and address them. And then, I also think that if we offer help whenever possible, it looks good for us. Now, I get it, we're very busy people. We can't be doing everybody's job all the time, but a patient rolls in off the EMS stretcher, I put my gloves on, I help move them over to the bed. In Louisiana, we got a lot of bigger patients, and it is important to have many people to save your back to get them moved over. So, showing that you're a team player, helping while I'm interviewing the patient, helping them take off the shirt while the nurse is putting on the leads, little things like that go a long way to demonstrating that this is a team. I'm not above, helping out because it is important. I expect you to help me too, you know? And so I think little things like that are important. I'll say that if I have a colleague that's super overwhelmed, and I see that they're drowning, it's hard to go up to them and be like, hey, what do you need from me? Because a lot of times people are so in the weeds, they don't even know what needs to be delegated, you know? And so if I see that somebody is struggling, maybe, you know, it's a colleague running a code, and I'm just happen to be walking by, and I'm like, hey, what do you need from me? Instead, like a lot of people don't know, just observe the environment and look for a way to help. It can be as something as moving a mayo stand out of the way, grabbing a piece of equipment, you know, like, I mean, it doesn't take too much. So I just say that, you know, looking for an opportunity to help and then just anticipating that action and doing it demonstrates that that's what, you know, I'm setting an example of how I think a team should function, you know, and I anticipate that, you know, my nurses pick up on those cues and end up doing the same. They anticipate my actions and bring me things without asking, and you know, I do the same for them, you know? And so if I see them blow an IV and I'm staying right next to the IV card, I just grab out another 18 and put it, you know, on the mail stand next to them so that they don't have to get up, you know? And those little actions speak volumes in the end. Oh, I got more tips, I'm sorry. The other thing I'll say is this one I stole from, you know, the Team Steps, which, you know, is a big initiative and all the resources are available online for it. But it's basically, you know, how do teams function? How do teams communicate? And one of the big things that I took away from that is the cuss mnemonic. And we're not talking about like the 4-letter word, but we're talking about like, I am concerned, help me understand, and stop this as a safety issue. But I teach my team during the huddle about those vocabulary words. Those are good ways to get my attention. You know, if I'm blowing something off and they're like, hey, I'm really concerned about the patient in room 8. You know, we already gave them 1 milligram of Dilaudid. They're still in pain. They really look uncomfortable. And I'm like, currently with a respiratory distress. But if they say, I am concerned, you know, help me understand why. Or, you know, I think that this is a safety issue. It is like a marker to communicate with me that like they're escalating the issue. They're using those buzzwords to get my attention. Same thing, I can do it with them, I can do it with consultants, but it helps us communicate in a way where we all understand each other's language. And then the last thing I'll say is simulation when it comes to communication, team dynamics, that is like the best. Now, I'm not a sim person, and depending on your institution, you might not have a big old fancy sim center, but you don't even need it. I embrace the in situ sim, meaning like, you know, it's a slow night, we have a trauma bay empty, let's run a sim trauma, you know, where something goes wrong, where there's a medication error, where there's a communication error, where there's a disagreement in plans, and how are we gonna, and then we'll debrief afterwards and discuss, like, how did that go? How could it go better, you know? But I think that, you know, whenever you try to do that with people, they're definitely like, think it sounds really silly, like that stupid exercise. They're like, oh my God, okay, Rainey's gonna make me go do this. But I'm telling you, after you run it, after you talk about it, people are like, oh, that was really helpful. And I do have ideas about how we could do this better, or, you know, you understand other people's workflow, and it goes a long way. But communication is a skill, just like innovation, just like placing a chest tube. You know, it feels uncomfortable at first, you're gonna make mistakes, but you will only get better through practice. And so using sim, even that lo-fi in situ sim, can be extraordinarily helpful to helping you be better at these skills and to create a more sustainable culture change.
When I saw this pop up, I saw cussing pop up on your during your talk. I was all excited. I was like, man, I got this one nailed. And then I said, oh, wait a second. That's concern, understand, safety issue. And actually, that's an important thing. And I think part of that openness, that transparency rolls into this. Is your staff, your nurses especially, are they comfortable in talking with you about a concern they have? And I actually have multiple times a shift. Nurses will come up and say, help me understand how we did it this way, or why we did it this way, or why did you think of that, or what was the reason we went that direction, and helping them understand and educate on how the process works and why you thought about that and the thing that tipped you off. And because then not only do you educate and help them advance their careers, but also because emergency medicine does tend to be a younger nursing career. I mean, they tend to move on to other areas of the hospital over time, just the burnout that all of us suffer with the constant pressures of emergency medicine. But it helps educate them, but also helps them look for things, but also that openness to come and talk to you and say, hey, listen, I actually am concerned about this. It's not going the way we expected, so help me understand what's the next steps, or can you come recheck it, or what should we do next? And that open communication, because I mentioned it earlier, the nurses will save your butts more often than you would ever imagine, because of that close interaction with the patients and the families, and the stories that are different. And as an attending, residents out there, you always get frustrated because the attending gets a little bit different story. Of course,
always.
the story the second and third time through is a lot more polished. They remember things that they had forgotten earlier. And so you get in also the experience of asking those specific questions based on the things that we have seen in the past, and that the exposures to certain things that should be triggers to say, oh crap, we need to think about this. So it's a new topic, different topic. I didn't say it's a new topic. It's a different topic. We talk about a lot of the practice-based, symptom-based, pathology-based, but improving team dynamics is important for us in emergency medicine. Talking with Dr. Randy Sorge. How can folks get in touch with you if they have questions, want to communicate with you moving forward?
Oh yeah, absolutely. So my email is rsorge, my last name Sorge, at lsuhsc.edu. But honestly, Gmail is the best way. So it's rmsorge@gmail.com.
Yeah, that's a lot easier. I agree. I agree. If it was lsu.edu, but there's other things added in, that makes it a little bit more complicated.
Yeah.
So, and as for me, you can contact me, rstanton@acep.org, rstanton@acep.org, at EverydayMed on Twitter. Also invite you to follow us along on Facebook on ACEP Frontline, and subscribe to the podcast on whatever platform you like, because we're on most of them, and get every weekly download. And now that we're starting to see a drawdown of some of the COVID actions, we're seeing more in-person conferences, and we'll hope to bring you more traditional type ACEP Frontline podcasts from these conferences, and topics to help you improve your practice no matter where you are. And as for me, I'm Dr. Ryan Stanton, and you've been listening to ACEP Frontline.